All right. Welcome everyone. Good morning, good afternoon, good evening, depending on where you're from. Wanted to welcome you to this final session for the day. My name is Professor Dragan Ilic. I am from the School of Public Health and Preventive Medicine, and it gives me great pleasure to welcome you all to this session, which I know will be a fantastic session in which we're going to debate and discuss the topic of what should we teach students about evidence-based medicine or healthcare. We've got a wonderful panel headed up by Professor Gordon Guyatt, who needs no introduction as an absolute doyen of evidence-based medicine and one of the four founders. We've also got a wonderful presentation by Professor Paul Glasziou from the Institute of Evidence-Based Healthcare at Bond University. Unfortunately, Paul couldn't join us live today, but he has sent through a presentation, and that will help us with framing our discussions moving forward. We've also got Professor Leonila Dans, or Inde, who's from the Department of Pediatrics and the Department of Clinical Epidemiology from the University of the Philippines, who will be providing her perspective from the region and how EBM has been taught over the years. And then rounding off our presentations is Dr. David Nunan, who is very much assured that he is very well known to a lot of you, particularly those of you who have done his course through the Centre of Evidence-Based Medicine at the University of Oxford. Once we've got those presentations done and dusted, we're going to be joined also by Dr. Loai AlBarqouni, who's an assistant professor and works closely with Professor Paul Glasziou at Bond University. Once we've got those presentations, as I said, completed, we're going to participate in hopefully a very active online debate, discussion, however you want to call it, between our panelists. And as we're working our way through the presentations, I'd highly encourage you to also submit your questions. There is a Q&A box down the bottom of your Zoom link. So please feel free to position and submit your questions, and we will look to incorporate them as we go along over the next couple of hours. I'm going to leave it there, and I'm going to hand over to Professor Gordon Guyatt, who is going to kick us off in terms of our topic today. So Gordon, are you okay to share your screen and kick us off?
I am certainly okay to try and share my screen. Whether I will succeed or not is another matter. People might have gathered that we had a few technical problems at the start. Let's see. Share screen, looks like it's going to let me share. So hopefully you now see the PowerPoint, and in a second you will see the PowerPoint in presentation mode. Is that right?
Fantastic. Yep.
Okay,
wonderful.
Brilliant.
Okay.
Okay.
To you, Gordon.
Thank you very much. So here is one perspective on how we should teach evidence-based medicine in the 21st century. I should confess initially to conflicts of interest. I am the co-chair of the GRADE working group, and you're going to hear about GRADE. And I'm a consultant to UpToDate, and you may hear UpToDate mentioned either in the presentation or the subsequent discussion. If any of you want to look for a paper that describes the essence, and actually most of what I'm going to say was published a little while ago, Kari Tikkanen and me, about the issue exactly that we are addressing. How should we teach evidence-based medicine? And as you see, evidence summaries and their applicability, not critical appraisal, are the core skills of medical curriculum. So in terms of an agenda for what I'm going to say, I'm going to start with critical appraisal before evidence-based medicine, EBM at the start and its evolution, and then the implications, 3 implications for evidence-based education, 3 challenges for the future. Dave Sackett was my mentor, the mentor of many of the people who ended up as leaders in evidence-based medicine. And he got the ball started with critical appraisal of the medical literature way back in 1981. He published or led the publication in the Canadian Medical Association Journal of a number of articles which became quite famous about how to read clinical journals, why to read them and how to start reading them critically. And so, right there in the title, how to start reading journals critically. And here was some of the suggestions he made about what to pick and what to look at. Title interesting. Do the authors have a good track record? We dropped that one after. And then other criteria, and then the possible purposes, that to use a diagnostic test to learn about prognosis, etiology and causation, and distinguish useless from even harmful therapy. And then below that, he has, for each of the purposes, what we would now call a risk of bias criterion. And at the bottom, he says, read the patients and methods section. When I talk about critical appraisal in this conversation, I'm going to be referring just to that, the patients and methods section. I'm going to talk about critical appraisal. People might use the words in other ways, but I'm going to talk about critical appraisal, about looking at the patients and methods. And I'm going to make the case that David was prescient in many ways, but it turns out in this way, he was misguided, because our clinicians are not going to be reading the patients and methods sections. And I'm going to argue they shouldn't, because they don't have the skills and the time. They should be looking elsewhere. So here in 1991 was the first article that used in the medical literature that used the term evidence-based medicine. And to give you an idea of how long ago that was, this is what I looked like when I published this paper in the ACP Journal Club. Just at that time, I was taking over as the director of the internal medicine residency program, which position I served for 7 years between 90 and 97. And what I pictured this and how I tried to use my role is as a laboratory for evidence-based medicine education. And I started with a lofty vision. Every graduate of my internal residency program would be able to read the methods and the results and assess what we then call the validity of the article that they were reading, what we now refer to as risk of bias. At the end of my 7 years, I had been brought down to earth. I had realized that despite my quite intense efforts to educate my residents in doing that critical appraisal, very few could appraise the methods. And my conclusion at that point was that the advice in the 1981 CMAJ to read the methods was in fact misguided. And in the year 2000, I was one of a group of us who made the case for what I had just concluded, for the result of my experience as residency director, in an article published in the PMJ that said that not all clinicians need to appraise evidence from scratch. As it turned out, I now say almost none do, but all need some skills. And what I'll come to is the skills that they will need. So what did the paper say? Finding and appraising the relevant evidence is not realistic. Learning EBM skills is not the best way to achieve evidence-based practice. Few will have the training. Those who do often won't have the time. And at that time, it's suggested look at pre-appraised systematic reviews. Well, that was more than 20 years ago, and things have advanced further. My position, some might characterize, has become even more extreme. So the goal of critical appraisal of primary studies and critical appraisal of systematic reviews is unrealistic. But I still teach them in a much more limited way. I still do teach them, but why do I teach them? Only for appreciation of the process, not so my learners, I'm talking about clinicians, learners, not so they can do it themselves, only so that they get a sense that there is a way of looking at the literature that makes sense, that is intuitive, that is rigorous, and that at the end of that process, when somebody tells them, this is high, moderate, low, or very low certainty evidence, and I'll come further to that, they can believe it, and they can say to themselves, well, I don't know how to do it, but there was, and I don't remember much of the details about how they do it, but there was a time when I saw this process make sense, that it has a firm grounding. And as a result, when somebody tells me about the certainty or quality of the evidence, I'm going to believe it. But they can't stop there. They still have to, and this should be the focus of our education, they still have to understand the results. Why? Because they are faced with patients who are trading off when they are choosing the interventions they will use and not use. They are always trading off benefits, harms, and burdens. And the clinicians, if they're doing a good job at evidence-based practice, will also be doing shared decision-making. And to do shared decision-making, you better understand the results, because otherwise you're lost when trying to communicate them to your patients and helping patients make the right choice for them. Well, how well do clinicians currently understand the results? Back in 2016, led by Brad Johnston, we published a study where we asked that question. We took 6 ways of presenting continuous variables: standardized mean differences, ratio of means, minimally important difference units, relative and absolute effects. We had internal and family medicine staff and trainees attending teaching sessions in Canada, Chile, Norway, Spain, Lebanon, US, Switzerland, and Finland. And for any of you who want to do surveys and bemoan the fact that it's very difficult to get above 30% completion, the way you get an 87 completion rate is you take captive audiences attending rounds, and you get the organizers to give you 10 minutes to give your survey. And then almost everybody who's there completes it. And that's what we did. So the participants were randomly assigned to one of 4 versions of the questionnaire. They got small or large effects, and we tested their understanding. We asked them to say, are the effects described here trivial, small, moderate, and large? And here's what happened. No surprise, we thought that risk difference would be best understood and relative risk next best. Beyond that, ratio of means, standardized mean difference, MID and natural units were hopeless. But the disturbing thing, and I remain somewhat disturbed at how depressing these results were, even the one that they understood the best, the risk difference, they only got it right 40% of the time. Clinicians, these clinicians at least, did not really know how to understand the results in terms of making a correct inference about the magnitude of effect. So what emerges from all that? I am starting from the point that I believe that a lot of teachers of EBM are still misguided. They think we should have critical appraisal, and I've told you what I mean by critical appraisal, as a major focus. They are misguided. We need to get EBM teachers to accept reality. Most clinicians will seldom ever do critical appraisal. I described it. They will not be reading the methods, but they will be making decisions and counseling patients on the right course of action for that patient in trading off benefits and downside. And to do so, they have to understand the results, but the evidence that we have available suggests that they cannot do this very well currently. We need to get EBM teachers to understand these implications, to substantially de-emphasize critical appraisal in their teaching, and instead substitute a focus on understanding the results. When will we have achieved our goal? When we repeat our study that we did with Brad Johnston and find out that clinicians can now understand the results of the studies that for the results of which they are using when they provide patient care. Well, next thing I'm going to do is talk about grade. So this is the first publication about grade in the BMJ in 2004. And it was, what I'm going to suggest is that what clinicians look at nowadays are guidelines. They sure don't look at the methods. They look at up-to-date Dynamed and the guidelines from the authoritative professional bodies. And what they need to be able to do is understand the quality of the evidence and the strength of recommendations that emerge from such guidelines when they are done in a trustworthy way. And what grade is about is an approach that the guidelines, that the people doing the systematic reviews and inform the guidelines, and the guidelines themselves will use. And when they present that, when clinicians have to understand not to apply grade themselves, but to understand the output of grade, of the application of grade. Well, why am I not embarrassed to tell you, oh, everybody should understand grade, given that I have played a major role in it? Well, my justification is that it has very wide uptake, and I'd like to believe that we've done a good enough job with grade that it warrants that very, very wide uptake. So you can see over 110 organizations have adopted, including the World Health Organization, leading American organizations like the American Thoracic Society and the American College of Physicians, and the lay clinicians worldwide, #1 resource up to date has 10,000 graded recommendations. So how does grade work? Randomized trials start as high certainty evidence, but may be rated down if there's problems in the body of evidence that include risk of bias, inconsistency, indirectness, imprecision, or publication bias. So randomized trials that start as high certainty, but with these problems can end up with moderate, low, or even very low certainty. Observational studies start as low, but particularly with large or very large effects may be rated up. So what clinicians will be faced with is estimates of the certainty of evidence as high, moderate, low, and very low. So challenge #2, clinicians are relying on guidelines. That is where they really do look more and more, and overwhelmingly, I would say worldwide, it's an enormous reliance on guidelines. Good guidelines, trustworthy guidelines, will present the quality evidence, and most trustworthy guidelines, maybe almost all, maybe in the not too distant future all, will be using the grade approach. Excuse me. So when will we be successful now? When clinicians understand the quality or certainty of the evidence and the basics of the grade approach. The third issue I'm going to raise is another pillar of evidence-based practice, which is that evidence by itself never tells you what to do. It's evidence in the context of values and preferences. A study to illustrate done by P.J. Devereux some years ago, patients present with atrial fibrillation. Anticoagulation lowers the risk of stroke with atrial fibrillation at the cost of more GI bleeds. Without treatment, patients will suffer 12 strokes. Anticoagulation decreased the strokes in 100 from 12 to 4, 8 fewer strokes. And then Dr. Devereux asked his physicians and patients, how many serious GI bleeds would you accept in 100 patients and still be willing to administer or take anticoagulants? Would it be, you can think yourself, 5 or fewer, 6 to 10, 11 to 15, 16 to 20, or more than 20 bleeds that you would accept to prevent 8 strokes? Well, here's what happened when Dr. Devereux asked 63 physicians and 61 patients. You see in the physicians a flat distribution. Some said, to prevent 8 strokes, I wouldn't even accept 5 bleeds, 5 to 10, 10 to 15, and then some a higher number. At medical grand rounds and such places around the world, I have repeatedly asked this question to clinicians and replicated Professor Devereux's findings. But look at the patients. 2/3 of the patients are ready to accept over 20 bleeds to prevent 8 strokes. They are much more bleeding averse than are the clinicians. And if you want to get it right for the patients, you'd better use the patient's values and preferences and not the clinicians. But another message is that at the other end, a small number, but still some of the patients have values and preferences closer to the physicians. They are much more bleeding averse and less stroke averse than most other patients. So to get it absolutely right, you can't use average patient values and preferences. You have to find out about the values and preferences of your patient. So grade says that patient preferences is at the heart of the recommendations that guidelines should make. Strong recommendations they should make when almost all fully informed patients would make the same choice. If they've got it right, a strong recommendation, you don't have to spend a lot of time on shared decision-making because all or almost all patients will make the same choice. A weaker conditional recommendation, your choice has to reflect values and preferences. And that also has implications for decision aids and quality of care criteria. And I've told you, UpToDate has made over 10,000 recommendations, 2/3 of which are weak and 1/3 of which are strong. And if clinicians are going to practice evidence-based medicine, they have to be able to distinguish between a strong just do it recommendation and a weak recommendation that mandates shared decision-making. So the third challenge, clinicians and guideline developers must distinguish between the just do it situations that warrant strong recommendations or the situations that are value and preference sensitive that mandate weak recommendations and shared decision-making. Will be successful when clinicians do shared decision-making when it's appropriate. And that's because they will understand and have the evidence summaries that will allow them to do informed shared decision-making. They understand what strong and weak recommendations, and every guideline that they use has a clear value and preference statement. So, in summary, 3 challenges in teaching EBM. Clinicians must understand the results, and to get them to understand the results, we have to teach them about guidelines, about grade, about how to interpret results, not about critical appraisal. We will be successful when clinicians understand guidelines. They understand what we mean by high, moderate, low, and very low quality of evidence, and what we mean by strong and weak recommendations. And when both clinicians and guideline developers understand how crucial it is most of the decisions we help patients with will be value and preference sensitive, and values and preferences are at the core of evidence-based medicine. Thanks very much. So I will now stop sharing and we can move on.
Fantastic. Thank you so much, Gordon. That was a wonderful presentation as always. So I am now going to try and get Paul's presentation up and running. So just bear with me for 1 second. Whoops. Apologies, we'll get there.
Well, you're letting our audience take a breath after the first presentation.
There we go. I've finally worked out. Okay. So I will oops. I will be sharing the presentation from Professor Paul Glasziou. Please let me know if I I've marked up the sound, but hopefully in about 3 seconds you should be hearing from Paul.
So, good morning, good afternoon, or good middle of the night, depending upon what time zone you're in. I'm Paul Glasziou, and I'm sorry I can't be there live, but unfortunately another commitment has prevented me from joining in on this session live. I'm sure it's going to be fascinating. It's addressing a very important topic, which is what should we teach about evidence-based medicine? And clearly the consensus on this has been moving over the last particularly decade, that we're shifting away from teaching so much critical appraisal and focusing more on interpreting, applying evidence. But the question is, what's the right mix? And so I'm sure this will be an illuminating discussion about that, both the presentations and the discussion that we'll hear afterwards. So I'm just going to give some brief notes about my thoughts about where we might move to, that I think aren't too far from what Gordon Guyatt has said or will be saying, but with a few wrinkles and differences as well, and a few different ways of framing the problem. Before I look at that, I just wanted to say, do we still need to teach evidence-based medicine at all? And absolutely, I think everyone would agree, yes, we need to teach something about evidence-based medicine. The question is what? Because what's the alternative? So in a very amusing article on 7 alternatives to evidence-based medicine that was published in the BMJ in 1999, the authors suggested the other alternatives were evidence-based medicine, eminence-based medicine, vehemence-based medicine, eloquence-based medicine, providence-based medicine, diffidence-based medicine, nervousness-based medicine, and confidence-based medicine. The last, they said, only applied to surgeons though. So we have to have an alternative, and these are some amusing alternatives, but in fact I think the key alternative would be mechanism-based medicine, which is largely what I was taught in medical school. That is, being able to decide on whether something is effective or not based upon principles about our understanding of the pathophysiology, etc. Unfortunately, important though the pathophysiology is, and it's been crucial in thinking about how we can develop vaccines, for example, or diagnostic tests for COVID, all of those things are based on our excellent understanding of mechanisms which are improving. But unfortunately, they can never tell us the size of the effect. And they rarely can tell us what the potential harms may be. So as one example of that, this is an article from the Mayo Clinic about how eating fish can help your heart. Unfortunately, it doesn't tell us how much it can help. So the pathophysiology of this may suggest some mechanisms whereby fish might help, or omega-3s in particular, but how much does it help? And the only way we can still do that is to use the clinical trials. So this is a meta-analysis of those clinical trials saying it maybe works, but if so, its effect is pretty small. And it doesn't tell us about the potential harms as well. As I said, pathophysiology rarely suggests that, particularly there are usually surprise harms that will come along. And so any decision about the balance of benefits and harms almost always requires this sort of empirical evidence that we see in evidence-based medicine. That is the randomized trials for things, decisions about treatment, or diagnostic accuracy studies for decisions about diagnostic accuracy, etc. So I want to use an analogy of radiology to think about how much we should teach and in what parts of the process we should teach. So radiology was first invented in 1896. That was the first clinical use of an X-ray, stemming out of Marie Curie's work. In the 1900s, the American Röntgen Ray Society was formed. And interestingly, in 1920, the Society of Radiographers, separating out the people that take the X-rays from the people that interpret the X-rays. And when I was at medical school in the 1970s, radiology was still being taught. We were examined on how well we could read various basic X-rays of the skeleton or chest X-rays, etc. And I'm sure most of the medical schools I know still teach some basics of radiology, even though for over a century we've had radiologists and radiographers to help with this process. So what's the equivalent in evidence-based medicine? Well, let's think of the radiology tasks. You've got to order the right image. You've got to take that image, it's the radiography. You've got to read the X-ray, read the radiology report, and then use the results for the decisions. So that's the flow of things. And you will still require, even if there are radiologists and radiographers around, many of those skills. You at least need to be able to order the right imaging study. Taking an image is pretty rare, though I used to do it in one of the practices that I worked in the 1990s. Have to be able to read X-rays occasionally on the weekend in emergency departments, for example. You certainly have to be able to read the radiology report and use the results for decision making. So the evidence-based medicine equivalent tasks would be asking a clinical question. We will still need to be able to do that. I can't see us ever losing that need to be able to teach the basics of PICOs, for example. And we still need to be able to find the evidence. Clinical librarians may help us. They're the sort of equivalent of radiographers, of actually getting us the thing that we want. But there are insufficient clinical librarians to satisfy the needs of all of the clinicians at the moment. So often we will need to be able to track down the appropriate guideline or secondary resource. Reading the research paper, it's becoming more common that clinical epidemiologists or other methodologists will have taken the paper apart and reassembled it in some sort of evidence synthesis or guideline. But there are still gaps in that we will still need to fill, and I'll talk about those in a moment. And we certainly need to be able to read the right pre-appraised evidence and then use those results for decision making. So while I think we've moved in evidence-based medicine towards the last two, to 4 and 5, we will still always need step number 1. And because we don't have sufficient clinical epidemiologists and clinical librarians, we still need some abilities within 2 and 3. Maybe that will change as radiology has, to shift more over the coming decades. But at the moment, we need skills in all of those areas, but with a shift towards the end. So I want to briefly touch on number 3 in reading a research paper, an original primary paper, which I think we still occasionally need. For example, when the Women's Health Initiative trial, which found that hormone replacement therapy appeared not to be the magic bullet that people had claimed from observational studies, but here was a large trial that stopped early because of the increased harms, such as the increased breast cancer risk. We had a flood of phone calls in my practice from women wanting to know what to do about this in the press the next day, as soon as it came out. So we held an emergency journal club because we weren't getting any secondary resources or guidelines. In fact, the national guideline took 6 weeks just to be taken down from the website and was never replaced. So the emergency journal club, to get us to go through it, was important to be able to answer the questions of all of those patients coming in to the practice to say, should I still be on this? Okay, that was 20 years ago. Have things changed? Well, I think they've changed quite a lot, but there's still some need. So during the pandemic, for example, with our local infectious diseases group, we held an infectious diseases journal club. And every fortnight we'd meet to talk about what issues they were having problems with, for which they didn't have an appropriate guideline at the moment, even though they were being rapidly developed by the task force in Australia. And so we would work through some of those questions with the ID doctors, but here it was a mix. It was like having the radiologists in the room with the clinicians a little bit. So an example of this was the use of dexamethasone. The recovery trial had come out. We wanted to know whether which patients you should apply the effective treatment of dexamethasone to, because there was an interaction. So we needed to look at whether this was valid, but then also about the clinical decision-making of who it applied to based on the primary study. At that stage, just a preprint, in fact. So of all of these competencies then across those 5 steps that I was talking about for radiologists and evidence-based medicine, which ones do we still need to be teaching? So several of the current panel that are here today were involved in this Delphi survey, where we identified 68 core competencies, 23 that only needed a mention, 23 that needed some explaining, and 21 that actually needed specific practice. So I want to look at some of the examples of what we need to practice. So here are the ones for practicing. Interpret presentations of the pooling of studies such as forest plots and summary of findings tables. So that's not doing a systematic review, but being able to interpret the forest plot that's at the end, or even better, a summary of findings table, but interpreting those numerical results, what they mean, what the quality of evidence, heterogeneity, etc. means, is important to being able to apply the evidence for patients. So I actually need practice with that. Interpreting results including different effect measures, again applying relative risks and perhaps transferring them to an absolute risk in our particular patient is an important skill. And again, we need practice with that. And finally, distinguishing evidence-based from opinion-based clinical guidelines, because a lot of guidelines are still not evidence-based, so we need the skill to be able to navigate that. And understanding some general principles about evidence-based medicine and the philosophical basis of it are important, but then also the specific skill of being able to look at whether this is a good guideline or not. And again, practice, 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 so that you can do that rapidly enough to be able to use this in practice, just like you would with reading a radiologist's report. So let's just look at that last one. We need a couple of things, which is which guideline. In fact, a step before that might be even, we need to find the guideline if it hasn't been delivered to us. So there's both push and pull issues that we need to be able to cope with. And there may be many guidelines in the area, and we'll need to be able to say which of these we think are adequately evidence-based. And of the evidence-based ones, we might then look at, well, which ones actually present that sort of numbers about the risks and benefits in ways that would help us individualise the decisions for our patients. So, can't judge just by the colour or the lovely colour schemes of all of these guidelines. We actually need some skills in being able to pick which ones are the good ones. And if there's no guideline, we'll need some skills in looking at other pre-appraised evidence resources. So how might this actually look in practice? So again, the team here has done an experiment where we looked at trying to teach evidence-based medicine starting with those end steps. It's almost starting with the radiologist's report and then applying it in a clinical decision. So we took some of the lovely evidence profiles that have been published by the MAGIC collaboration that are published in the BMJ and use those to teach people about what numbers mean, how they might individualize those, and how you might communicate those with a patient for a process of shared decision making. But that led people to then think, well, where do these numbers come from? And can I trust them? And how would I find them? So starting at the end leads us to a process that asks about those other questions in evidence-based medicine. And we think it's a better way to teach. That certainly in this study, we found that the skills were developed and also people enjoyed the process. So in summary, we still need evidence-based medicine. We still need to teach it. We still need to practice it, but the emphasis has changed. We need lots of practice at interpreting evidence, strong skills. We need to be able to look at effect measures and all of the statistics. We need to apply that to individual clinical decision-making and shared decision-making. But we still need some skills in being able to search and appraise, at least some basic skills in that area, especially when there are circumstances like the emergency journal clubs where there's no pre-appraised resources that are available. So I think we're shifting, but it's a mix. We still need skills in all of these steps, but we can also probably start at the end as well and use that to say, here's where you want to go. How are you going to get there? And ask the appropriate questions, find the evidence, and do the appraisals that you need to do, or get somebody else to do them for you. So that's my few pieces about this. I look forward to hearing about the discussions and what the final conclusions are about what you need. And I'm sorry that I'm not being able to be there live.
Okay, thank you very much to Paul. He's riveting, even though he isn't with us live and in person. Still a wonderful presentation. I'm going to now hand over to my final two colleagues, Indy and then David, to present their thoughts. And whilst they're doing that, I would again highly encourage all of our audience members, if you do have any questions that you would like to ask our panel as we progress towards a panel discussion, please pop them in the Q&A box. Indy, are you okay to take us forward?
Yes, I'll try to do that. Can you see my slides?
Yep, perfect.
Can you hear me? Okay. Okay, so thank you very much for inviting me. So let me share with you some of my thoughts on this and share with you the experience that we've been having in our area. So my potential conflicts would be, I've been teaching EBM for more than 25 years, and I've contributed in some of the evidence-based journals and book. We have a book called Painless EBM. But I think I should add here that both Gord and Paul are my mentors, and therefore I think that can create potential conflict. I'd like to say that, you know, I've been teaching for more than 25 years, but it is only when the COVID pandemic started that I realized how useful and important evidence-based medicine is going to be, you know, and that's started to be to play a big role in how our COVID response was shaped. So we were in a lockdown. We had a lot of problems with regard to the response. This is a low resource setting, and the pandemic just opened up like the Pandora's box, and we learned so many things that has existed. We knew this before, but pandemic has actually spotlighted it. From conflicted relationships, weak health information system, social inequities, hospital centrism, workforce deficiencies. But I'd like to focus on commercialized medicine, because this is where evidence-based medicine, the skills in evidence-based medicine had played a big role, especially in our setting. Even at the very start of the pandemic, you know, with so much unknown, there was a proliferation of a lot of claims of how to counter this condition that we know nothing about at the start. And I think that brought us to what the ivermectin saga. The ivermectin push in the country, in the Philippines, has been there even at the very start. And I'll give you two examples to illustrate where our EBM skills were challenged during these times. Let me show you one. So in those two examples, where we were shown the evidence, and we were asked our opinions regarding what to believe and what not to believe. So let me show you one of the first evidence that was used to push this new drug for new indication, old drug for a new indication. In this study, supposed to be coming from the IBM Meta website, this was used by the proponents of the use of ivermectin. They already had 27 randomized controlled trial at the time. That was May. This is May 2021. But you can see when we were shown this, it started. Obviously, we had to use our critical appraisal skills. There was pooling of different outcomes. As we look at this, they combine different types of patients. One is for treatment, one is for symptomatic patients, used for prophylaxis. They start, this meta-analysis disregarded heterogeneity in their forest plot, and there was no appraisal of the randomized controlled trials that they included in this study. And what was being pushed to us is that this was already being endorsed by a group called Frontline COVID-19 Critical Care Alliance. And they even said that there's somebody there who's an EVM expert coming from UK. So this showed a lot of impact, and even doctors started to prescribe this in our country. But the scenario became more complicated when our politicians came into the scene and started to use this ivermectin. So we started to actively be part of the advocacy, and the recommendations are being asked from our group. So we were actually questioned in the Congress hearing. We were accused of not using the existing evidence. One of the more common questions is that how many studies do you need to be able to be convinced that ivermectin works? Because they were showing us that meta-analysis. We were even accused of not knowing how to conduct systematic reviews. And what is actually their clincher is that we were accused of depriving the poor of an already proven effective drug, and this is something that the poor can actually afford. So at the time, we felt that there should be more basis in claims like this. What we did is call our students, our students who have been taking evidence-based medicine, and we were able to get 90 clinical epidemiologists and health professionals to volunteer to conduct rapid reviews for all these issues that are coming out during the initial part of the COVID pandemic. We were able to complete 69 rapid reviews, and that warranted more than basic skills in EBM. What is interesting is we had more than 100,000 visits in our online resource for these rapid reviews in 2 months. We actually made a unified algorithm for this and had 175,000 visits. So that means this is being used not only by healthcare workers, but also policymakers, some patients, and people from our Department of Health. So this helped a lot and became the jumping board for making more formal clinical practice guideline recommendations. We had a living COVID-19, living Living COVID-19 clinical practice guideline using the grade approach and more formal way of doing the recommendations. So the second article that I'd like to show, which was only shared this was published in June, but started to be shared all over our chat groups, no, in the country. This is the use of oral human ivermectin, and what was interesting here is that survey from 8, this was only a survey of 8 physicians already prescribing or proponents of that drug. And they had 338 patients and claimed 96% of these patients recovered after being given early at the start of your COVID. And their conclusion was that ivermectin is effective for COVID infection, provided it's given early and dose is adjusted. And this was being shared in our Viber groups. Philippines experts have shown that ivermectin confirms that this works, and it is validated by local Philippine experts. And you will note the main author here, unfortunately, came from our Department of Clinical Epidemiology. And so this became a little disturbing. People started to ask us, should we answer formally? Should we have a press release regarding this? Because some of our colleagues were concerned. So what we did is we consulted one of those computer geeks who try to monitor impact of this kind of online resource. And what is actually interesting is what he said was that this source actually had zero impact. There were no sharing of the links nor downloading of the articles. So I guess in this respect, although it was being shared in our Viber groups, people were saying there was no control group. It was only a survey. So I think they had colleagues, healthcare workers, had some skills already in assessing whether this is a good proof, no, that ivermectin should not be part of the recommendations for COVID. So to answer the main question that was brought to us for this discussion panel, my sense, having those two examples, is that the depth of learning should still be individualized depending on the role that you play, whether you're in the academe, you're a specialist, you're a clinical specialist, you're primary care practitioner, policymaker, or clinical epidemiologist. In the first article, we had clinical epidemiologists helping us provide the rapid reviews to show that evidence is needed, to support those claims. And then in the latter part, we learned that having had all these EBM workshop in the past 25 years maybe helped in making sure that these kinds of something that might have been viral actually didn't have much impact with regards the use of that drug. And then I think that aside from individualizing the depth of learning, some of the things that we feel should be basic skills when we teach evidence-based medicine should be, number one, is to keep our students staying curious. When claims are abound and there's a crisis, they have to stay on their toes and ask the question, make it a habit to challenge others, and also encourage others to challenge you. Remember, the first proponents and even some of our colleagues, some of the doctors who are claiming for that drug are very angry when they started to be challenged when we showed the critical appraisal of the claims that they had or the evidence that they had been showing. But the fourth basic skill that I'd like to share is that, which is harder to teach, is to do all this. 1, 2, 3 cannot be done without a sense of irreverence. Irreverence is not being rude, but being able to not take yourself too seriously, being able to question and be questioned, and not to take it personally and be objective on the way we answer things. And So to end, I'd like to say, to quote some excerpt from this article on evidence-based medicine and COVID-19, what to believe and when to change. The article says that the pandemic requires all of us to reach new level of EBM characterized by skepticism, thoughtfulness, responsiveness, and clinical agility in practice. But we must collectively do all that we can to ensure that our response to the pandemic is based on science and be rational and not include, base it on emotional, political, and economic issues that challenge it. But I think this can be successfully done, whether it's pandemic or not, depending on your role. You must have the right set of skills, the right level of skills, as well as the right attitude in practicing evidence-based medicine. I think I'll end there. Thank you.
Thank you so much, India. That was a wonderful presentation and nicely highlighting the context that you faced most recently. So we're going to move on to our final presenter before we open up our discussion. So I'm going to hand over to David Nunan from the Centre of Evidence-Based Medicine at Oxford, and I think David's got a wonderful presentation that'll tie us neatly together and progress us to the next stage. So David, over to yourself.
Okay, thanks, Dragan. Hopefully you can all hear me. Dragan, I thumbs up that my volume's coming in okay. Perfect. Excellent. Brilliant. And I'll share my screen. Great to hear the talks from all the other speakers, and no mean feat following on from these esteemed colleagues. But I'll do my best, and hopefully you can all see my screen okay. There we go. How's that, Dragan? Is that okay?
Perfect. Perfect. Okay. Over to you.
Excellent. Brilliant. Yes, and just to say also thank you to the course organisers for inviting me to talk today and be part of this panel. Very much looking forward to the discussions. And thanks also to those of you who have managed to stay up and be present for this session. In my part of the world, it's certainly getting on. So thank you very much. Yes, so by declarations and way of conflicts, here are some of mine. And Gordon, I apologise for the last one, but Paul was very much the first introduction to EBHC, but I've very much been inspired by yourself and others as well, of course, as we go. Much of the stuff that I'm talking about in this presentation, I've discussed in various other formats, so you can find those available in the sources that I've given here. And I have actually chosen. I was given a 10-minute slot, so I will be brief with my presentation, and we can get straight to the panel. But I did focus on what Gordon and Paul were saying in their sessions, and we had the slides from them beforehand, so I could have a focus on this. And I have seen Gordon and Paul sort of talk about their areas as well. And I think I'm in agreement with a lot of what both Paul and Gordon are saying. Of course, woe be me not to be in agreement with them, but just even looking at their own discussions, that I think, as Paul alluded to, I think they're also in agreement very much with themselves. And I think if I was to focus down on Gordon's angle of where he's arriving at and coming with, it's this idea of trustworthiness, finding a trustworthiness source, trustworthiness, either the form of a pre-appraised guidelines, and certainly obviously with the grade process, and I think if you look across where there's some synergies and I think relationships between agreements, I think Paul and Gordon's idea on what makes a good trustworthy evidence-based guideline, and perhaps that's where the sort of pre-appraised and the sort of certainty of evidence and grade comes in. I think in terms of the way they're talking about interpreting the numbers and the usefulness of numbers and how that's going to inform shared decision making. And again, I would agree that those are important aspects. And I think perhaps maybe one of the areas where there's perhaps a little bit of a slight movement away from each other is the idea that we stick to sort of thinking about the 5 steps. And as we saw in Paul's presentation, the idea of appraising, treatment studies, primary studies, and also systematic reviews and the importance of that. And I think that's kind of led me to a place where I'll focus on the idea of what does it mean to be evidence-based is it a move to trust-based and guideline-based? And I guess in some senses, has that always been the case? I think there's something to talk about on the numbers specifically, and here I'll sort of present my ideas of where I'm thinking in terms of how we go about presenting the numbers and what that looks like, and being fair to those numbers as well. And I think I'll also focus on for me, there's a bottom line to the answer that we give when we ask, why did you make that decision? Why did you make that recommendation to give that test or to give that treatment? And then I think in terms of focusing down onto what that means for what we should be teaching about evidence-based healthcare, I think there's something around focusing on looking at what we can learn from the educational literature and looking at critical roles when we're evaluating our teaching programs. So just to focus on trustworthiness, and I think questions I'll be raising at the panel, and I look forward to Gordon's response, and I think I can probably anticipate some of those, but perhaps not, around, well, what does trustworthiness actually look like, and how do you go about then teaching trustworthiness once you know what it is you're looking for? And I think we also need to be cautious, I think, if we're going to proceed with trust-based and trustworthiness as our base for which we're going to start making our decisions, and calling that evidence-based practice. And I think we don't have to look too far back in time to a particular period in 2018 when there was a bit of a fallout with the Cochrane group around one of their seminal systematic reviews around the treatment of with HPV vaccine. And for a full story behind this, I recommend you go and read Hilda Bastian's blog, who absolutely perfectly dictates and takes you through the actual key issues. But one of the fallouts from that I was seeing come out was this idea that there already seemed to be an implicit trust built into some of these organizations, including Cochrane, as we can understand. And it seemed that clinicians, once they'd sort of, now that trust had been questioned, they were a loss of where they should go next for their guidance. And I think that's something we need to think about if we're going to start leaving clinicians relying on trust of others. Where are they left if all the skills they've got is to find those trustworthiness sources and rely on them? And I think another good example comes from the recent NICE guidance, and I'm sure many of us, if you're familiar with the UK and even outside the UK, are probably familiar with NICE, the UK independent guideline developers and panelists and producers. And they came up with a new guideline, an updated guideline for ME and chronic fatigue syndrome back in 2021. And one of the recommendations that they made in that guidance was a recommendation which differed to a previous recommendation, was to not offer people with ME, CFS physical activity or exercise programs, particularly ones that were going to be based on a deconditioning or exercise avoidance theories, which had a strong background to it. And part of the reason as to why this guideline made this change, one of them was because of the previous Cochrane review on this particular topic had been pointed out as having been criticised for its potential, the way that it went around assessing the potential risk of biases in the included studies. And another part of the reason for this change in recommendation was because of harms that were reported by people with ME, CFS in the qualitative evidence. And now when you go and look at both of those, if you take your critical appraisal skills and you go and look at those evidence bases in terms of the quality evidence base and those potential biases, you can actually see that there's actually potential gaps in that evidence base itself. But how well the NICE panelists and the NICE reviewers looked at that evidence with a critical eye themselves, and made fair judgments of that evidence. I think there's questions there when you look at that evidence base. It led to a bit of a furore, and where 4 members of the NICE guidance committee stood down, and also other prominent EBMers and people involved in evidence synthesis were questioning the actual veracity of the guidelines themselves and the process itself. And so that generates a potential issue, of a loss of trust again. And where do we now go if our NICE guidelines are also no longer trustworthy? Where do I go? Where do I look? I have to wait for the next trustworthy guideline to come along. And then I think finally, there's another example from our own work where if you go and look at this review, it did a great job in terms of meeting some of the tests of trustworthiness. So it was pre-registered, it had good systematic review methodology and very good reporting. But when you applied the actual critical skills of looking at the evidence base in a bit more detail, it became apparent that there were serious problems. So much so that the article ended up being retracted. And the issue here is that if you're relying on others to do this work for you, they may simply just miss it and promote work that has been overlooked in terms of in some of the issues. So I think we need to be mindful overall of the potential pitfalls if we're going to move to a place where we're fully relying on others to inform us about research evidence. Just going to quickly pivot to the numbers. So on the numbers, the person in the picture here is Dr. Margaret McCartney, who's a colleague and a co-worker at the Centre for Evidence-Based Medicine, a fellow. And when I've spoken to her about sort of where do numbers fit into your discussions and your consults, she's a practicing GP, but she's very, very up to date and skilled on the skills of EBM and how to describe the numbers and understand them and appraise evidence. And she simply says, I hardly ever use actual numbers in consultations, and she can't really recall how often it comes up. So I guess there's a question, and having spoken to other clinicians that I work with, I'm not sure how often these numbers do come up. And again, I'll have to refer to my clinical colleagues for this to confirm it. But how often do we bring these numbers up in consultations? How often do we describe them? Or how much do we rely on qualitative judgments of those numbers and the evidence? And I think that's something to look at. Also, I think even when we are doing the numbers right, well, are we actually? A discussion I've had recently on Twitter is the idea about your risk. And then I think the idea of that how much do we focus on the point estimates when we talk about numbers, and we don't necessarily consider the uncertainty and express the uncertainty in those numbers in enough detail. And I think part of the issue with your risk that I'm exploring, and I'm by no means there yet with how I'm thinking on this, but I think when we talk about your risk and we present that to a patient, I think somehow in their own mind, they have this bucket full of risk, of how much risk they have and how much no risk they have. And then when we give a treatment, which is based on evidence from groups, from averages in groups of people, they may have this misconception that their risk levels go up and down, and the treatment that they're getting, they will be the beneficiary of that potential risk reduction. And of course, we know when we express these things, if we express them in the right way, that actually, 10 people may get better, 10 people may stay the same, and 80 people are never going to get harmed anyway. And we can't tell which one of those people you're going to be. And so I'm not quite sure, and I'm still exploring with that, where even if we are going to try and start using the numbers, if we're expressing them in the right way. And then I think in terms of uncertainty and just talking about point estimates and expressing those in our communications, well, public health are pretty guilty of this pretty much all the time, and are very, very reluctant to express any uncertainty. But even in clinical scenarios, we have examples within guidelines where little of the uncertainty is expressed, and we often focus on that point estimate, and how fair is that to the evidence base that we're actually basing these numbers on. And I think just wanted to think about, for me, a fundamental driver of determining what we should be teaching in terms of evidence-based healthcare skills is the answer we're going to give to the question why. So why did you make that decision or that recommendation to do that particular test or give that intervention? And I think in terms of the sort of evidence to underpin any decision, it's going to range from anything to like observations. This is how I was taught, what we've always done, or there isn't any or much evidence, all the way to the other end of the extreme, which I think is the 5 steps, and going through the full process of finding the evidence, asking the right question, finding the best evidence, and appraising it down to the degree of understanding the risk of biases within the study designs that you found, the clinical and the clinical, not just the statistical significance of the findings, how to express that, and then how to apply that in a shared decision making process, considering all the other relevant factors that go into a shared decision. And then I think on that spectrum, there's somewhere in the middle, which seems to be that middle ground that we're talking about, starting to move towards, where it's someone else's sort of done the work of looking for you and doing that appraisal for you, and then sharing that with you and summarizing it for you. And that's where you're gonna get your answer as to why. And hopefully, we hope embedded in with all that wherever you are on that spectrum, that you're including not just the evidence, as Gordon said, it never stands on its own. There are other things, and I quite like Rod Jackson's way that he puts it with this, the X for experience, or the X factor, where you pull and push between these different important other considerations when you're making a decision. And I think how often people can and want to go to the furthest extreme on this line of really understanding the evidence, I can't really answer that because I don't know, but I'd like to know. And I think once we get a good answer as to how people want to answer the question why, I think that will help us dictate where on the spectrum of EBM skills do we need to be teaching towards. And then finally, I think I'll point out that when we spoke with Paul, myself and a colleague of mine, Professor Kamal Matani, we spoke with Paul back in March 2021 about his leadership and his teaching experience in evidence-based healthcare. And one of the comments he made, which is relevant to this particular discussion, was that we're still struggling with how much people need to know about clinical epidemiology concepts to be able to use them in practice. And I wonder if perhaps if we look at the educational literature, we might find a way to sort of to answer some of these problems. Some of you might be familiar with the Kirkpatrick model, which looks to evaluate how often how a given training or learning program has created training or learning effectiveness. And it's got 4 levels of evaluation, categorized by their level of importance as a measure of effectiveness. It starts with the lower levels, including participation, reaction, and learning, and the degree to which the intended knowledge, skills, and attitudes have been acquired. But then it moves up to evaluating changes in behavior. So addressing if learners apply what they learn when they return to their actual jobs. And it specifically targets critical behaviors, which are those behaviors, those few specific actions which are critical for desired results. And I wonder if perhaps if we focus on what are the critical actions, behaviors of health professionals in clinical practice, we might be able to identify which specific EBH skills, if any, to best focus on. And I'm not aware of much work in this area, but that could quite easily be my own ignorance. So if anyone watching is aware of relevant evidence in this space, then I'd certainly welcome sharing this. But in the meantime, what I might like to do, if that's possible, is ask you watching now to copy this QR code using your phones, or if you've got your if you just want to type in the copy the URL address down below, and maybe we can pop it in the chat as well, Dragan, if that's possible. Just to help me fill out this questionnaire to actually get an idea if you are a health professional, healthcare practitioner dealing with patients and individual patient decision making, where we can start to get an idea of what some of these critical roles and actions are, and then we can start to see where some of the EBM skills that we might need to fulfill some of those will fit. So certainly welcome any participation in that survey if you can, and I'll finish there and open up for the panel. Thank you.
Thanks so much, David. And we'll just let that final slide on for people if they want to use their phone and scan it. I've just scanned it, so thanks so much. I'm not sure about others. It's just from my perspective, I was planning on being in Melbourne, but I'm in actually Berlin, and it's about 30 in the morning here, and there's not a whole lot of things that would keep me up until 1:30 in the morning. But I've got to say, listening the last 4 speakers has truly kept me up and excited, and now I'd like to draw in Loai as well, who has worked closely with panel discussion, and he can also provide his input as we move towards our panel discussion. Like I mentioned, thoroughly engaging presentations all around, and I guess my first question, and I'll ask the audience to pop in their questions as well. Does what we teach, I guess, depend on where we are in terms of the audience from a novice to expert level? So whether we're is what we're teaching, do we need to modify it for, our first-year medical student, as opposed to a fifth-year medical student, as opposed to someone who's been 5 years out? Thoughts, perspectives? Gordon, I might start with you and then
Sure, thanks.
open it up to the rest of the panel.
The answer is fundamentally not much. People, what are people going to remember? We don't remember anything except under extraordinary circumstances when we hear it once, or even twice, or even 3 times. What people remember is what they hear multiple times. And for any of you who are health professionals, you can think of the first time you heard all sorts of things that you now take it routinely, and how many times you had to hear it, and then how many times you had to experience it in the clinical setting before it really became something that you knew very well. So that what what you are presenting in each case, that I do, is a little bit of time, less and less, on the fundamentals of critical appraisal, and then what is a relative risk? What is an absolute risk? How does one decide what are patients interested in, the relative risk or the absolute risk? How do you balance when you have the effects and the benefits and harms? What is certainty of evidence? How do you take into account, how do you deal with high, moderate, low, and very low certainty evidence? I do it wherever I am. In the, as people get more and more senior, the process becomes more and more quickly. You can see that they have grasped more, and the discussion that ensues goes on at a higher level. And by the time by the time they are farther along, where the first time you might spend a whole hour on one part of one example, and by the time that they are they've heard it for the 10th time, you might have a session where you go through the complete evaluation of 2 or 3 bodies of evidence or clinical questions. So it's always the same stuff, tailored, however, in the way you present it, how quickly you go through it, how much you try to cover, with the where the learner is at, and the extent of exposure and the extent of expertise that they have developed prior to your teaching that particular group.
Thanks, Gordon. I'll open up to the other panel members. Thoughts and maybe responses to Gordon?
Can I say something?
Yeah, indeed. Go for it.
Yeah, so I'd like to add to what Gordon said about hearing it several times and actually, it's sticking. One of the other things that we have learned teaching evidence-based medicine, it also helps that they read. So sometimes you give them protected time. So during the session, they hear it, they understand it, they know it, but after a few days, they just lose it. What we have learned is if they know where to look for it, the right resource, sometimes that helps them identify the need as the need arises, where to look for them in their, whether they read it online or they read it in your book. The other thing is I mentioned about Gord was saying that really depends on their expertise, actually their interest as well, as you go down into, as you delve deeper into the technical issues. I think it's highly important to know where they're going to use the knowledge, the skill that they're trying to learn. If in my examples, we needed somebody to do the rapid reviews, so that we can present a more organized, structured support to our recommendations. So we needed more skills, more in-depth knowledge. While when we were just looking at, something that goes viral and some basic skills is needed. So primary care providers would know where to look for good practice guidelines, what to look for in some of the studies that are being presented to them. Just the fact that they needed some control group or a comparison group might be important in their decision whether to accept the evidence that is being presented. So highly individualized. You have to learn a little more and identify where to go back when it's needed.
Fantastic. Thank you, Inday. David or Loai, anything else to add before Loai? I might ask you a question following up shortly. Nope.
So maybe I'm thinking about them. So thinking about their reaction to those knowledge, even if it's the same kind of teaching, their reaction will be different according to their experience. I think that's one of the observations that we found. Teaching the same kind of concept for first, second year medical students completely different to those who have been practicing for a few years.
Mm-hmm. And just on that, Loai, I mean, Paul in his presentation made reference to the core competencies that paper and what you led. I mean, do you agree with the notion that we should be just focusing on the practice elements rather than the other two components when teaching?
Yeah, I think that's what's also written in the actual article. It has been written that there should be more move towards the interpretation of the evidence rather than the critical appraisal. But I think one of the also another challenge is that we face from the other co-author and from talking to others about other disciplines. For example, those who are physiotherapists, allied health, all of those that doesn't have that well-established clinical practice guideline as in the medical, in medicine, and also in the public health field. So we have a Master of Healthcare Innovation, and we are teaching those kind of principles. They don't have those well-developed, trustworthy guidelines that they can refer to. So in that instance, they need to have those kind of skills to do that critical appraisal of the evidence. But I agree with some of the discussion that that should motivation for those disciplines to have those kind of establishment for the guidelines. So I think in the article itself, that move have been discussed, and I totally agree with that. No point for disagree.
Great. David, I might hand over to you for a sec. We've got earlier in our panel, Gordon was talking about growth, Paul was talking about magic, and you tied it together nicely regarding trustworthiness. Can you expand on, can we teach trustworthiness? I'm trying to get that out. Trustworthiness. What is that a component of EBM that we need to tease out some more?
Well, yeah, as I think I alluded to in my talk, I think we do need to tease it out more. I can see, and when I've read Gordon's work and his paper on what that trustworthiness might look like, it's about having an established process in which the evidence has been judged. I think grade provides that. One of the strongest points for me for grade isn't necessarily the things that are covered. And I asked Gordon why he chose them once, and he responded quite nicely with, well, tell me what else we should include in there, and I didn't really have an answer. So, but one of the great things is and this is what I think is fundamental about any system of judging of the evidence, is that you tell me how you've arrived at those judgments. And what's great about grade is that if you do it right, and that's one of the issues, is the doing it right. If you do it right, it tells you, it kind of drives your hand to say, well, this is how we've judged the evidence in this way. This is how we've considered, and if you move that into a guideline process, this is how we've considered that evidence that we've judged in this very transparent way. in light of the the patient values and preferences and other considerations and coming up with our recommendations. So it's a very transparent process. Two things: you need to know what that process is, I think, and have a good understanding of what grade does and doesn't do in order to know whether the reviewers themselves have applied grade appropriately. And I have seen some examples of misappropriate, I would say, uses of grade, or changes to the way the scoring's been done, turning a 1 to a 0.5 reduction in terms of the scoring system. And I'm like, so I think there's elements of, is that breaking the trustworthiness? If you slightly go off piece, then I guess only Gordon will be able to, be the best person to answer that question. But when does that stop being, meeting the definitions of trustworthiness according to that process? And then if you find another process with NICE, is their process just as trustworthy? So it lends us having to look around and think, well, what do we mean by trustworthiness? How do we judge it? And then how do we assess it?
Right. Thank you, David. Apologies, it seems my internet's a little bit unstable. So before I cut it, Gordon, I might hand over to you for counterpoint.
Well, about the trustworthiness. So we are, I think, there's a wonderful book called Thinking Fast and Slow, which one of the points that it makes about human reasoning and human behavior is that we are all afflicted by optimism bias. We think we're going to get done much more than we actually get done. We think we're being successful in communicating. And we have, in this case, much more optimism about what people are capable of, what clinicians are capable of, and are interested in, and I think we're actually completely deluded. When I look at when I did my 7 years of residency, I ran the program, at the end, I realized, my goodness, these people, they get out there, they're never going to look at the methods section once for the next 40 years. That became very evident. And if you say, if you even raise the possibility that they're going to have any hope of recognizing when grade is optimally or suboptimally done, forget it. That is as unrealistic as any idea that I could ever imagine. So it's got to be utterly simple. It's got to be utterly simple. So you tell them, and in fact, so I'm hugely, as enormously conflicted as anybody could be, because I've spent the last 15 years trying to get up to date to be truly evidence-based. And it would be very depressing for me to think I'd wasted my last 15 years in that regard. But that is it's the world's number one, it is the world's number one resource for clinicians. And thank goodness they're doing a decent job, which doesn't mean that they don't make mistakes. And whether you're talking about Cochrane or NICE or anybody, sometimes people are going to make mistakes. But don't kid yourself that the clinicians are going to recognize when they make a mistake or not. Hopefully, mistakes will be corrected. People will criticize. People will, as has been pointed out in the stories, the experts will, if one expert group makes a mistake, it's going to be criticized by some other expert group, and hopefully will be corrected, and often is. So let's just be realistic about what our clinicians are going to do. So one thing is, if they're using grade, that is great. That is as a litmus test, that is an excellent litmus test. Is something you should do. And then, do they present an evidence summary that you can understand? I'll tell you one huge success that I have found extraordinary. 15 years ago, when I put up a forest plot to a medical audience, I had to explain everything about that forest plot. I put up a forest plot in clinical audiences worldwide at the moment, and everybody understands the basics of what a forest plot will look like. there is a visual representation of the evidence that that clinicians to a remarkable extent compared to 15 years ago get. We have had some success. And down the line, if they then can understand a summary of findings table, there is my nirvana. They can understand a summary of findings table. If they can understand a summary of findings table, then we have made it a well-presented summary of findings table based on grade. So that is what we should be aiming at. And if you then say they use grade and you can understand their summary of findings table, man, that will be it.
Fantastic, Gordon. I think David's got a lovely question. So rather than me trying to butcher it, David, you're very much more eloquent at asking these questions. So I'm going to hand over to yourself to ask this for Gordon.
Yeah, sure. No, I realize as a panelist, I'm asking questions of Gordon and putting it all back on Gordon. But I guess I guess I'm fascinated, and I'm still in this space and trying to, you know, ask these questions to all practitioners that I see. But I'm really focusing on practitioners who what, you know, how much do they care about the answer they can give versus what they would like to give, as to why, you know, that, and that's what I put in my presentation as to when they answer the question, why have you made that particular decision? Why have you made a decision to give that treatment or do that test or whatever it is in your practice that you do? When I come to ask you why, and I don't know how often they get asked that question, but how far can they unpack that why? And are they okay with just stopping it? Well, it was done, you know, it was in a guideline and it was done in a grade guideline, or it was in a grade recommendation, or it was in a recommendation from NICE or wherever. Is that where we've got to, that's where they're happy with, that they can't unpack it any further than that? Why is just, you know, the best we can get to is that they know it's in a guideline.
Well, slightly farther. So, but clinicians operate, again, the guy who Daniel Kahneman, who wrote Thinking Fast and Slow, and the work with Tversky. And then when they look at how people behave, and when you look at how clinicians behave, they behave by heuristics. So my clinicians see a patient with heart failure, and what can they tell you? They can actually tell you that if you have reduced ejection fraction, that SGLT2 inhibitors now, and beta blockers, and ACE inhibitors, and angiotensin receptor blockers, all lower major events in people with heart failure. But that's what they can tell you. What more do they need to know? These, and if they intuitively realize, and it would be nice to get them to be able to be a little more explicit about this, why is it a good thing to give all this whole pile of stuff to people? It's because heart failure patients are at very high risk of dying. It's a bad, when people say it's actually, in terms of prognosis, worse than most cancers, which means the baseline risk is high. So you're getting a substantial absolute risk reduction with each of these. Now, they couldn't tell you that, but they know heart failure is bad news, and each of these things lower major events like mortality. So you give it to all your patients, and it's actually, strong recommendations are warranted in each case. And I could go through example after example where they're aware of just fundamental facts which come to down. When I see situation A, I do B because I know for very simple reasons it's a good idea. That's how clinicians operate. And so we want to make it clear to them what are the things that are warranted just to do it. But in other situations, they get a little more sophisticated, and then they see, okay, I know I'm trading off bleeding versus causing bleeding versus reducing thrombotic events. And then that is where we've got to teach them to say, okay, well, something about the magnitude of effects in the close calls. So but largely they operate by heuristics. In strong recommendations situations, that's great. See A, you do B, the patients are going to be better off. And then when I'm on the wards, I say, the first thing I say, any decision we're making, is this a value and preference sensitive decision? We need to teach the clinicians to stop and say, is this a value and preference sensitive decision? If the answer is no, heuristics are fine, you don't need to know very much. It works and it has an important effect. And when it's a value and preference sensitive decision, that's where we aren't doing too well. And that's where we've got to focus our teaching. When they're value and preference sensitive decisions, then they have to start getting into the why, because there's a trade-off which is going to differ, where different fully informed patients are going to make different choices.
Brilliant.
Can I
Thank
add?
Gordon. I'm going to, please, Indy. Yeah,
I was
go
going to
ahead,
say
sorry.
that sometimes just the clinicians asking the why is already success for me, because you know, Gordo's saying, you know, to teach them about grade and everything might be very difficult. Even as teaching them the difference between strong and weak recommendations, sometimes it's very difficult to get across. So the first step is to be curious. So if they ask why, and depends on how much they want the answer, it's already the first step to, you know, getting the right perspective and right approach to their clinical practice, hopefully evidence-based.
Wonderful. Thanks, Indy. I'm going to turn to a question. We've got our first question from the audience. So one big thank you to Jennifer for sitting, and encourage the others, whilst we've got another 10 or so minutes left in the session, to put through your questions. So Jennifer asked a related concept to how teaching is how we assess learning. So she's interested in the panel's thoughts in terms of assessing EBP knowledge, skills. I might also add in attitudes and behaviours in practice. How do we go about doing that? Or how do we go about doing that effectively? I don't want to dob in anyone, so I'll leave you to think about it. But I mean, for instance, we've got a variety of tools out there in terms of you know, validated tools. You know, is it as simple as using that, or you know, do we need to be more practical in our approaches in terms of assessing learning of EB and translating it into practice?
The stuff. So, number one, I don't bother. I've never bothered, and I never will bother, okay? And part of it is all those tools that are out there assess what people are never going to use unless they've just finished the course and it's the exam at the end, okay? The stuff is not, as I pointed, it's all about critical appraisal, right? If I were ever to do it, okay, so here's my evaluation. Okay, here's the evaluation that's impressed me. I've told you about it. 15 years ago, I got up and I put a slide with a forest plot, and nobody understood what the hell that was. And now, in medical audiences, I put up a forest plot, and people actually can understand the basics of what I'm putting in front of them. That's an extraordinary success of EBM education. And as I say, when the day comes when I can show a summary of findings table and they all immediately get it. But the stuff that's in these tests, that stuff that I would skim over, and I'd never expect anybody to remember.
Fantastic. David.
Well, actually, I was going to point to yourself and to Loai in terms of shared decision making. I think is one part of like How can we tell when someone's doing that well? What does that look like? And I'm not sure it's going to answer was it Jennifer's question in terms of, because I'm still searching for some of the answers to, well, how do we assess what looks like good shared decision making and what's the end point of that? Is it the decision was shared, tick, or is there some argue that actually the end goal of EBM is actually that you arrive at a way of of a shared decision, and that could be it. But how that gets assessed, maybe Loai, you can come in with some of your work, and obviously Dragan, I would put you down as one of the sort of kings of assessment, even if it is those assessments that Gordon was sort of talking about, the ones you've never used. I know you've got good experience with using those and developing some of those tools as well for those sorts of ideas.
Yeah, I was going to mention that shared decision making, because we are the moving is towards more.
We only try and we're
sorry,
assessing them at the end of the course. No, go ahead. Sorry, Lo.
Yeah, I was going to say about the shared decision making, because if the move toward the interpretation and use of the evidence, the actual use, how we can use the shared, because there are already developed tools to assess the quality of the decision making, the shared decision making, how we can use those tools to assess the quality of the training about evidence-based medicine. And some of this tool talking about whether the clinician talk about the benefit and harms, whether they have any quantification, whether we agree or not to use some of the number, any quantification of the benefit and harms, whether there was any effort to integrate the patient's value into preferences in the decision-making process. And that can be assessed from the clinician side, from the patient side, and also from audio recording. Some of these consultations have some assessment about the quality of the decision. So that could be one way how we can assess the quality of the decision making.
Yeah, so now that's great, and I admire you doing this, and it's a frontier area, because in terms of your point, David, I'm not deciding what is good shared decision making is something that it's a frontier area. Deciding what is good shared decision making and then starting to measure it. But now you're talking about looking at performance of actually people when they're interacting with patients. This is something different from the classroom and how to read an article. This is people actually doing EBM practice, where shared decision making is at the center of the practice. So to the extent that residency programs can start watching people and videoing them and all, my residency program, nobody watches anybody. Good luck. You're out with the patient. You're on your own with the patient. Nobody knows what's going on. So I think it's very admirable that you are starting now to think of addressing the things that really matter.
Yeah, but just if you would like to make it back to the classroom, sorry, just to make if you would like to make it back to the classroom, we can do it as an OSCE station. So what we trial to do it as an OSCE station, share decision making for the medical student, and do these tools to assess the quality of the decision.
Very good. And so what excellent, admirable. I'm impressed. What you're trying to do is simulate the clinical environment. So simulating the clinical environment, moving as much as you can to what's going on really in the clinical environment, that seems like a good approach to me. Now, how much it will actually transfer to what does happen in the clinical environment is another question. But to try and be simulating the clinical environment seems like a positive approach.
My threshold is a little lower. The way I gauge it is the fact that they're asking what the evidence, where the decision is coming from, and they're not afraid to be challenged and to challenge. I think are good gauge that you're getting across what evidence-based medicine is all about. The other interesting thing that I have noticed is that if there's an exam or an evaluation, that keeps the students motivated to read more and understand more what evidence-based medicine is all about. So if in that respect, if they're able to do that and be more motivated or inspired to read more about evidence-based medicine, I think the the goal is not to actually, as Gord was saying, they will never be able to answer, but for them to understand more what it is. I think you have achieved your objective.
Fantastic. Thanks, indeed. David, were you about to say something?
Well, I think just come to Indy's point, assessment
Apologies,
drives
my
learning.
internet's a little bit flaky, so I'm
Go ahead, David.
yes.
Dragan, I
So
think you're having real internet problems at the moment.
Yeah, Dragan, a bit slow there.
So go ahead, David, what you were going to say.
Oh, I was just going to say, I think it was coming to Leonila's point around, assessment drives learning. So wherever you stick assessment in, the students will learn it because they obviously have to for assessment. I guess the question is what are we sticking in? What are the fundamental things that we should be driving assessment? And I think we all know that for the last any assessment of curricula across the world, we all know that the first three things have been, and you're right, Gordon, have been the things that we've taught and the things we've assessed on, perhaps because they're the easier things to assess on. Do you understand X? Can you relay Y? Whereas I think Loai moving into the sort of steps 4 and 5 is where I think we should be going forward with teaching, and how we teach and assess about the apply bit. And even the process of how you evaluate your own EBM practice is another part where I think there's some of the gaps in the teaching and the assessment that we haven't quite narrowed those gaps just yet.
Apologies for my bandwidth. Apparently it's very low, so I'll try and get this last question out before we wrap up, and hopefully it comes through in one piece. Quite often when I ask our medical students, what does evidence-based medicine mean to them, they go back to that classic definition of clinical evidence and patient values and the best of our research. And our programs tend to focus, I think, on that critical appraisal aspect of the research evidence. So moving forward, do we need to focus more on shared decision-making, communication, but also the clinical expertise, the reflective practice of our students and as they go into becoming clinicians, of knowing what they know, knowing what they don't know, but also, to use the Rumfeld quote, the unknown unknowns. Do we need to place more emphasis on the communication and shared decision-making aspects, as well as the reflective practice aspects moving forward?
The short answer is absolutely yes. You have hit aspects that should be the focus. And as I'll say one last time, that should be one of the alternative focuses, along with just really being able to understand the benefits and harms and their certainty. That's the alternative focus, rather than spending much time on the critical appraisal.
Yeah, I'd agree. We definitely need to focus more on the move into the shared decision making side, the application of all that sort of evidence and how it matches with a shared decision, and also some of the assumptions that we make about shared decision making. So, is it always that a decision should be shared? Can a patient have a choice about whether they want to share a decision, and that choice could also not be fixed, right? They could come back the next time they see you and have a different decision as to whether they want to share or to what degree they want to share. And then how do we elicit how much they've understood about that shared decision making? So how do we arrive at knowing that was a truly shared decision, as it were? I think they're all areas that are just ripe for, what they're ripe for is, I think, unpacking and also what I'd like to see and share, and I would stress to the panel, is role models of this, good examples of this, examples of, and Loai, absolutely leading the way on this in terms of sharing some of the work you're doing, but also just role models on day-to-day practice. Who's doing this sort of stuff on a day-to-day basis, day in, day out? Or are we all, I often find when I'm talking to people, they tend to be people who are not day-to-day clinicians. They may have a little bit of practice, but actually they've been academics for the last 15, 20, 30 years, or, you know, moved out. So where are the people that are actually able, you know, can we do this on a day-to-day basis, and teach our clinicians how it can work on a day-to-day basis and share that experience with others? I think that's my goal, is to try and find those examples so we can share them with others to learn from.
Fantastic. I'm going to hand over to Indy and Loai for any final thoughts before we come to a close.
My final thoughts would be, more than the technical aspect of teaching EBM, you know, risk difference, all those technical terms, is actually teaching the right attitude, the right skills to perspective on how to approach clinical problems. One of the hardest things to teach is what we call irreverence, wherein you're not afraid to be curious, you're not afraid to be challenged. And if they're able to have that kind of approach in the clinical practice, they themselves, you cannot force them to read, you cannot force them to understand all these technical things if they're not interested. So if they have that kind of perspective, it helps a lot in going through understanding what evidence-based medicine and how they can apply this in their day-to-day practice. So I think that's something that we should add as a basic skill in trying to promote and practice evidence-based medicine.
Fantastic. Thank you. Lau, any final thoughts?
I think nothing to add to all those amazing panels. So one thing, maybe just a little bit, maybe at least the focus of the application, shared decision making, interpretation, that's great. But also not to forget about the critical thinking skills, something like the informed health choice skills. That's for everyone should be able to have those critical thinking skills. I think also important.
Brilliant. And Gordon, I might finish off with you. I mean, at the start of you kicked us off, and at the start you mentioned how things had or had not changed from when you initially started your course. If we're in a time machine moving forward 10 years from now, where do you see us being in terms of teaching EBM?
Where I would like to see us is that I've already alluded to, that I have the same experience with a summary of findings table as I've had with a forest plot, that people can look at it and get it. I like what Inde said, that we can have people who are irreverent and give that as an attitude throughout, as a matter of fact, medical practice, but captured by EBM, and that we are teaching shared decision making. That our clinicians start with every decision, and at least in the back of their minds, is this a value and preference sensitive decision or is it not? And if it is, that they actually know how to do shared decision making, and that Loai and Dragan and your colleagues have figured out how to measure it and can tell us how well they do.
We'll see how we go. Look, on that note, I just personally want to thank each and every one of you for your contribution and for staying up. I know you're all coming from different parts of the globe, so big thank you, Gordon. Big thank you, David, in particular. I know you're in London and it's, you know, well past midnight, 1 a.m. or whatever it is. India as well, and Loai, many thank you. Big thank you also to all of our colleagues who have joined us online. We've had over 100 people participating and viewing us. So many thanks for sticking with us. And thank you to all of the conference organisers for providing us with this platform that we can continue this dialogue. So on behalf of everyone, many thanks for the session today. This morning, tonight, where you're coming from. I've thoroughly enjoyed it, and very much looking forward to continuing this discussion moving forward. I think we'll we'll close the meeting now, and we haven't done too bad. We're only a minute over time, so I'll take that as a success. Thank you all, and take care.
Thank you.
Thank you.